dynamic nurse practitioners who, as I mentioned, are working across all different areas of the health system. I'll pass it on now to Elissa, who is going to be moderating this session. Thank you so much, Elissa, and please go ahead.
Okay, so great. I'm actually really, hold on one second. Let me just get my video going here. There we go. I'm actually really looking forward to this, to hearing about, kind of day-to-day practice, or otherwise a day in the life of NPs in Ontario. So I'd like to get started, and I just wanted to let you know I do have bios, and I think what I'm going to do is I will present the bio of each individual, and I'll have them talk a little bit, and then the next individual, et cetera, et cetera. So each person will have about 10 minutes or so to talk about what their role is like, how COVID has impacted it, et cetera. So just a quick mention about the objectives: to learn about critical and emerging roles of NPs, to appreciate how NPs are contributing to the SDGs and quadruple aim, and then just to engage in informal learning and dialogue. So I'm, again, as I told you, I was really looking forward to hearing about your roles. So I am going to, oops, hold on one second. Okay, so let's start. We're going to start with Tara Leach. And I'll just give you a little intro and bio for Tara. Tara is a primary healthcare nurse practitioner and sexual assault nurse examiner. She addresses violence from 4 pillars: research, policy, education, and frontline clinical perspective. Also, she's the founder and clinical director of the Health Clinic, HEALTH, Healthcare Education Advocacy Linkage for Trauma-Informed Healing. This clinic was the first primary care clinic in Ontario committed to providing patient-centered and trauma-informed primary health care to people aged 13 years and older who are at risk for or who have experienced coercion, exploitation, labor, and/or sex trafficking. Tara has worked tirelessly to enhance care for and advocacy of human trafficking, and has been a part of the Ontario network of sexual assault and domestic violence treatment centers. She is a certified sexual assault nurse examiner and an educator for the Ontario Sexual Assault Nurse Examiner Program. Additionally, Tara is also professor at Algonquin College in the Victimology Ontario College Graduate Certificate Program. Wow, that sounds really interesting. So Tara, we're gonna go for about 10 minutes to about, I would say to about 12:46, and I'd love to hear about your practice and how COVID has affected your practice, et cetera, et cetera.
Okay, great. Thank you so much for having me here today. Hello, everyone, and thank you for attending. Thank you to RNAO for allowing me to be part of this excellent working group and for providing the chance today to discuss my unique role as a nurse practitioner. So you mentioned in my bio, thank you so much for introducing me. Just a bit of a history. So I started nursing in 1997. This was a time of layoff for many nurses, and as such, I was forced to look at opportunities in the US as being a new graduate, as little option was left here in Ontario. I was quickly provided a position in Philadelphia in a pediatric emergency room, and it was here that I was actually inspired and introduced to the role of the nurse practitioner as well as the role of the forensic nurse. Upon my return to Canada in 2003, I was focused on the road ahead and was keen to becoming a nurse practitioner, and in 2007, of course, that dream came true. Throughout my career nursing, no matter the setting, I have always had the privilege of working with those who have experienced violence and who within the experience of violence have expressed extreme stigma and shame in accessing our healthcare system. Carrying the weight of stigma, this often resulted in unmet needs of the client because the true picture of their reality was not understood by the provider. As a result of this, my lens on routine primary care and my role as a nurse practitioner was necessarily incrementally adjusted and refocused to accommodate the breadth of violence and socioeconomic circumstances that were impacting patients' health. I began to imagine doing healthcare differently creating a setting where healthcare could be adapted and to be flexible to accommodate clients' needs, to incorporate into the practice the concepts of trauma-informed care, and to have full control of the implementation of this practice. I wanted to have partners in this work of being of those of lived experience who are able to assist patient care in the form of peer support and to evaluate the practice setting to ensure accessibility and socioeconomic needs of transportation or food access, et cetera, were met for clients. And within this vision, of course, was health. So as an NP embarking to open up their own clinic, I was tasked to learn the process of completing funding applications, understanding the role of governance and directorship, managing a budget, negotiating prices for medical equipment and EMRs, and of course, practicing outside the institutional healthcare setting, which was the area that I had practiced within the most. I mean, nurses establishing and running a clinic for fee-for-service was not unusual. However, the circumstance that I was faced with was obtaining funding to run a clinic that serves a vulnerable population, a population who wouldn't have the money to be able to pay fee-for-service and would likely not have the proper identification to access healthcare in Ontario, thereby challenging consultation to specialty service. So I found myself very much alone and uncertain of the path ahead, but of course, where there's a will, there's a way. Health was founded in 2017 following a successful funding application submitted to the Ministry of Children, Community and Social Services for Ontario's anti-human trafficking strategy. So what this meant was that I was going to be an NP-led clinic funded outside of the current model of NP-led clinics, which of course was within the Ministry of Health and Long-Term Care. Health was funded to be a trauma-informed primary care clinic, which is focused on the needs of those affected by sex and labor trafficking. Health utilizes a socio-ecological model of public health and is an example, as I've mentioned, in terms of flexible, adaptive model of care. We are funded to be open 2 days a week, which is Wednesdays and Fridays. And through Health, of course, I meet people of all genders, ages, documentation statuses, backgrounds, who are encountering a range of medical issues. So over the past 2 fiscal years that Health has been open, over 165 unique people have connected with the Health clinic and a total of 611 visits have been recorded. So again, I remind you, it's only open 2 days a week, which on average has the clinic open 80 days a year. People receive, or clients will receive, a range of acute, chronic, and preventative medical services such as diabetes care, chronic pain management, substance use disorder management, vaccinations, Pap smears or testing, injury documentation, HIV care, Hep C treatment, trans primary health care, and routine physicals. Running this specialized clinic within Ontario has had many benefits, but it's also revealed many ways in which the traditional healthcare system requires radical redesign to meet the needs of people who have experienced chronic and complex sexual trauma. There's a lot of goodwill that keeps this clinic running to serve the client who accesses it. Our current funding is not enough to run this clinic on the level that it needs to be. Certainly recommendations and being able to work with this committee within the NP task report that becomes very relevant to a clinic like mine, our government's understanding that NP-led clinics like Health exist and to understand the reasons why, to increase access to NP students like clinics like Health so that the application of trauma-informed principles can be practiced and not just learned in theory, to harmonize nurse practitioners' compensation so that within a funding application, it can be appreciated to any ministry, the cost benefit of a nurse practitioner, and then to also invest in research to support NP practice and to allocate and finance the time necessary for an NP like me to evaluate the implementation of a practice like Health and to be able to publish the demonstrated improved health outcomes derived from a clinic practice like Health. So Health has made me realize that highlighting the narratives of those whose vulnerable circumstances may be hidden at a population level and is an essential form of advocacy. Recommendations rooted in lessons learned from direct patient care offer complementary insight to lessons learned from population health research. Both are necessary to ensure that key stakeholders, including policymakers and health system entrepreneurs, consider the breadth of people's circumstances when they create policy, advocating funding, or designing their next healthcare app. Many of the lessons learned through my journey as an NP may be intuitive to some, but largely inapplicable to others. But to all of those listening to you today, I certainly say this, that I hope that you have the freedom to question whether innovations in research and policy account for your patient's circumstance and the opportunity to design solutions that do. And that I hope that you routinely check your own reflexes to make sure that the advice that you are taught to give is applicable to the clients that you are expected to help. I also wanted to, in terms of the introduction, in terms of the talking that about COVID, I will certainly say that in terms of COVID and the realities of human trafficking, is that it has dramatically increased within our province. Certainly the amount of people that are being exploited and coerced through means in that online. In terms of my general day-to-day practice, in terms of the applicability of the clinic, we've been able to have virtual access in that for clients and still continue with frontline access for clients. So I will say on the day-to-day, in terms of the impact of COVID, while it makes everything sort of a little bit more challenging, people have still been able to access care. And on my day-to-day, in terms of working as a nurse practitioner and working to full scope, I haven't necessarily seen a dramatic change. And so that was sort of what it is that I had prepared, and I sort of condensed it as we were talking, knowing that we're going over time so that we have opportunity for everybody to be able to say.
Wow, thank you for doing that. I would like to interject just one quick question. This is fascinating for me. What was it in your life or at the time in terms of your career that kind of gave you the impetus to start this clinic?
So honestly, when I look at my nursing career, I take a look at starting as a diploma RN, advancing onward to become an NP and doing my master's. I really had always sort of seen healthcare gaps for clients. And so what my motive was is try to make things easier. And so oftentimes within our system, there's a lot of rules and regulations that can apply and are there for good reason. But when we look at being accessible for people who are experienced violence, and for a lot of those folks are very marginalized, it became a system that was very inaccessible. So I started to just see where could I fill these gaps. And then when I became an NP and the NP scope sort of blew up, sort of in 2011, I was able to say, you know what, I can look at this differently and I can actually do something independent, and I could actually run my own clinic and do things the way that I would like to do them, and actually trial this idea of what trauma-informed healthcare could look like, this adaptable and sort of flexible model, to really trial it and say, well, if we did it this way, would it make a difference? And so over the couple of years that I've been able to do this, the reality is, yes, indeed, it does make a difference. So it's really been the privilege of being able to live in Ontario, the expansion of the scope of practice, and then the realization that an NP can actually do this. But of course, which is always the challenge, is sustainability and funding.
Yeah, I'm sure. I would just like to say this is another perfect example of how actually forward thinking that I think my colleagues in Canada are, because you do have expanded scope of practice and the ability to do this quite easily. So my hat's off to you and all of your colleagues. So that was so interesting. Thank you. So I think what we'll do is we'll move on to the next person. And the next person is Hoodo Abdi Ibrahim. And I hope I pronounced that correctly. Huda began her career, Huda began her career in healthcare as a personal support worker. Hold on one second. Sorry, I don't know if you could hear that. My phone was ringing and I wanted to make sure that you wouldn't be able to hear that. So she began her career as in healthcare as a personal support worker, and also worked as an RPN, RN, and is now an NP. She's certified as a family nurse practitioner and as well in mental health and addiction. Currently, Huda position at St. Joseph's Healthcare, Hamilton, in the schizophrenia outpatient clinic, and a causal RN position in the acquired brain injury program at Hamilton Health Sciences. She's also a faculty member in the Department of Nursing at Mohawk College of Applied Arts and Technology. She's an active RNAO member with the Mental Health Nurses Interest Group and NP Interest Group. She's passionate about promoting evidence-driven knowledge transition, individual capacity building, social justices, and stigma-free healthcare services for all. So Hudo, are you there? And would you like to present and tell us a little bit about your life as an NP for the next 10 minutes or so?
Good afternoon. Thank you to all the task members, facilitators, and the chairs of this amazingly upcoming report. Yes, I am extremely excited about this. And as a task group member, I just would like to share a little bit about my position. I work currently as a nurse practitioner, as mentioned, at Schizophrenia Outpatient Clinic. In this clinic, we serve two types of clients. Primarily, each individual has to have either diagnosed with schizophrenia, psychosis, or schizoaffective. But majority of those clients come with multitude comorbidities, including the addiction, medical comorbidities, and etc. So actually, my position, I am the first nurse practitioner in that clinic, and this position was lobbied for over 5 years for the manager trying to sell why she needs this position. I serve adults anywhere from early 20s to end of life. My job primarily is to do, I call the Wheel of Fortune. And the reason I call Wheel of Fortune is I have absolutely no limitations in regards to what I do in that clinic. And mainly I can thank to the autonomy that's given to me. But at the same time, like Doris said, we could be our own enemy by causing barriers and limitations, saying we can't do this, we can't do that. Up to 65% of my clients have multiple comorbidities, like I said, and they face great challenges accessing primary care, specialists, and anything they need due to lack of ability to actually communicate for themselves what they need, sometimes lack of insight, sometimes they don't know what is missing. So there is a multitude barriers faced by this group of people. And when I walk in, anybody can walk in, and it can go from a cardiac to tachycardia to vital signs to mental health to a liver failure to yesterday someone who needs Friday someone who needs a transfusion ASAP. So there is no prediction. So I say the Wheel of Fortune, you wheel it, wherever it drops, that's what I'm doing the next minute. So in terms of my job, there is 4 different areas I focus on. Primary care, which I provide anything that family doctor provides and beyond. And the reason I'm saying beyond is 90% of my clients, I can write all the referrals. I can send them, to the liver specialist for Hep C that had been diagnosed 20 years ago. I can send them to the ortho. I can send them to anywhere, but they will not go. And therefore, they get dismissed and they never get the follow-up that they require. So in 10, what I do, I gain the consultation through e-consult or directly contacting the doctor and etc. And I execute the treatment in myself. But in terms of the liver doctor, I try to make sure that our staff are available to take them, accompany them, and support them throughout the transition until their cure and have, what can I say, favorable outcome. So in terms of the primary care, like I have no limit whatsoever. It could be a pregnant woman, it could be, whatever that hand falls in my lap, I serve. I also spend a lot of time advocacy. And advocacy, what I mean is our clients don't know their rights. They don't know what they can get and what they cannot get, and they don't have money resources. So I dig in every single where I can. And again, it is that borderline of, are you being aggressive or are you being assertive? So suddenly I agree with Barb, like, you're being assertive or a little bit aggressive doesn't mean you're not nice, as long as you're going about the right way. So I do whatever it takes to push for them as long as it benefits my client. As I said, I am also specialized in addiction. So I provide addiction management such as opioid treatment, alcohol use disorder management, and any substances my clients. And lately, my greatest revelation have been met-induced wound care. So that there is no limit of what I can do in those individuals. Another thing I fulfill is I am I am the MRP for number of clients who are on clozapine and have been at this clinic over 20 years, but cannot be transitioned to a family doctor or anybody because no one is willing to take them. However, from status quo, they are stable enough to be transitioned. So I have absolutely like from primary care to psychiatry to addiction, no limitations in that aspect. Another thing I do is a lot of consultation. A lot of the clients that come to our clinic, we get about 30% referrals a month. So what we do is like, you know, some are intake, some are diagnostic clarifications, and some are medication consultation. So I do provide some medication consultations for the family doctors. If the client does not need to be admitted to our clinic, but they just need, you know, this medication used to work for them, it's not working anymore, and we're talking about psychiatric medications. As I worked as a nurse 16 years in the psychiatric, I feel quite comfortable. So I do provide a lot of bridging for family doctors as well, who are willing to take on our clients who are on clozapine. So I do what we call knowledge translation. I assess their comfort zone and I teach them what they need. And at the same time, I provide a follow-up period where if anything goes wrong with the client and they need a consultation, they call me and I support them managing the client, or I take the client back for a small period of a time, stabilize them, and then send them back. So in a nutshell, that is majority of my job, but I am super, super excited like this to become a model of almost every primary care provider and mental health. I think holistic care is the way to go, and it should not be divided. I think clients should be going in wherever they are and getting all the services that they can receive. And I also still do precepting with university students and etc. because in my opinion, we need to lay the eggs for the next upcoming groups of practitioners, and especially in mental health. It doesn't attract a lot of people. So anybody who is passionate about, I am more than welcoming them.
Hello, my name is Pri calling. Right now I'm working Parkwood Institute of Mental Health as a clinical lead. I'm doing my nurse practitioners program as a primary healthcare nurse. I'm so happy to hear from you. I wish I should shadow with you some period of time.
Absolutely. There are protocols that you have to follow, especially with the COVID when it comes to shadowing me at the workplace, but I do that as well. I can send you my, I'm not so sure how you can get my contact information, but I can definitely help you out in that aspect.
How I can reach you, like I don't know how I can reach your contact.
I can put my, or maybe
guys, just to help everybody, I suggest you send private emails on the chat so we can get moving, and you can give your contact and she will connect with you. Thanks.
Oh, thank you so much. Thank you.
Thank you.
Okay.
Doris and Hoodo, I was very impressed to hear that, and I hope, Doris, that your policymakers and stakeholders in Ontario are hearing these stories, because what they're doing, I mean, it's amazing.
So the work of Tara is well known already to government, and the Premier's office is looking into that because Ontario launched a strategy for human trafficking. So they are looking into that, and yes, stay tuned. Stay tuned.
Oh, great. Thank you so much, Hoodo. That was so interesting. Thank you. Okay, so what we'll do is we'll move on to Wendy Dunn. Wendy has worked with older adults since the age of 14 when she was a nurse's aide, and her passion has always been to improve the quality of life for those at end stage of chronic diseases. She graduated with her MScN in 1994 from the University of Western Ontario, and her first RN job was at Greenwood Court in Stratford. She was the charge nurse the first evening its doors opened. She's worked as an RN in long-term care in multiple roles, palliative care and rehab, in an acute care setting, and a case manager for Community Care Access Center. She has completed her MN, Acute Care Nurse Practitioner Program, in 2001 and has worked for 10 years as a geriatric nurse practitioner. In May 2016, Greenwood Court and Knollcrest Lodge secured Ministry of Health funding for a shared attending nurse practitioner, and she's been in this role working with a fantastic multidisciplinary team to provide care and loving it. So that's great. And I would say, Wendy, this is interesting, and I bet you have a lot of stories about how COVID has affected your practice. So please tell us about yourself.
I am very honored to be part of this panel. My goodness. I don't come with the qualifications and the wonderful, wonderful work. I've just landed into a lovely job that fits who I am as a person, I think, and as a nurse. And Barbara Stillwell, my gosh, I loved your talk. I think every nurse should hear that. So I'm hoping it is recorded and I can show it to the nurses that they can hear it, that I work with. So life in long-term care has changed with COVID. I'm not going to go there or I will cry. So I will just talk about the role as an NP in long-term care. And Barbara, a couple of your points really hit home with me because it's a fairly new role still in long-term care. And a lot of people that we work with in long-term care have never worked with nurse practitioners before, especially in this setting. And in terms of nursing, I know you spoke to that, the study that was done in China. And I would say that long-term care, it is nurses that run the show as well. Our care is almost 100% driven by nursing, I would say, with a little bit of sprinkling of physician support, maybe once a week in a home, and then sprinkling of physiotherapy support, maybe once a week in a home. Some homes have more, depending on your size. Dietitian sprinkling. So it is very nursing driven, and I've worked in long-term care my whole career. Started as a healthcare aide when I was 14 and had the luxury of working in many different roles, and I love it. You gotta love it. And I love how Barbara talked about everybody has a little piece of their jigsaw. My piece is long-term care. I think people that work in long-term care do because of that passion. It's a beautiful role to build relationships, long-term relationships, and you can really make a difference in end of life. And there's so much work that can be done on an advanced practice nursing level in long-term care. It's been highly missed, and it was actually why I went into my nurse practitioner, because the physicians can't fix things in long-term care anymore. It's medicine hits an end, and nursing can really take over. And as a nurse practitioner, you really can make a big difference. In terms of scope, I work to full scope for sure, full scope plus probably, because a lot of my clientele cannot physically get out to see any specialist. So I do a lot of e-consult like Huda does as well. And you do a lot of, COVID has actually helped that. We can actually get specialists on the phone now because they're not seeing people in the office, and they will actually talk to me as a nurse practitioner because I'm right there beside them now. So it's actually made a nice difference with that. But my youngest resident that lives in long-term care is a year younger than me. I actually played soccer with her when she was diagnosed with MS. It's kind of crazy. I grew up in this little small town, but MS, and I probably diagnosed a breast cancer that she probably had for about 4 years when I started and treated. So you can go from treating a 48-year-old with primary care. She probably hadn't had a PAP done in 10, 12 years. So, right, you can do that kind of scope all the way to my oldest right now is 101 with multiple comorbidities. So it's not just old and frail people, it is many in between and many mental health that can't manage in the community, land in long-term care, and then the complexity with end-of-life care always. So that's my sell on it as being a very good place to work as a nurse practitioner. And the nurses love you, right? So I get to use my full scope, which is wonderful. I actually feel like a nurse again. I guess I worked in hospital as an NP in geriatrics, along with the geriatric team for 2.5 years after I graduated. And that was huge for me because I was always a long-term care nurse. And let me tell you, a totally different philosophy of care. And that was hard for me. I did a lot of that was when all that elder-friendly work came in. I did a lot of restraint decreasing. We actually got people dressed in hospital. They never really liked to see me coming, but we used to get them dressed and up for every meal and to maintain the function that they had so that they could potentially get back home. So did that for a couple of years, and then worked in primary care for 8.5 years, which was fantastic too. I needed that to do what I'm doing in long-term care now. And they soon figured out I loved geriatrics, so I ended up making my own role where I did a lot of home visits. Anybody who was confused or failing, they would just say, go see Wendy, and Wendy would work through a lot of the issues. But I do love long-term care for sure. I'm not sure where I was going with that talk about me, but anyhow, I will say when I started, another little thing Barbara said when you started was around syringing ears. And I actually have a personal story about syringing ears. I have one set of docs in the one home I work with that had about 4 residents, wouldn't let me see them, refused to let me see them because they had residents that they wanted to have manage their care. And it was so inconsistent. It was just awful, the inconsistencies, right? Because it was somebody new coming every 3 months, who'd have the same ideas. And it was so poor and the only thing she would let me do was syringe their ears. After she had looked in them, she would leave a note, NP can syringe ears. It'd be like, oh, here I am like 12 years in, and that's all they think I can do, still syringe ears. Now that has come full circle because COVID happened in long-term care, and all of a sudden no physicians entered the building. 0 physicians entered the building. And we were at the brink of, well, we had an outbreak in April, the beginning of April, right at the start of COVID. And this is where, Doris, I'm going to cry. You shouldn't ask me to do this, but it was really hard. And we didn't have anybody walk in but nurses for 9 weeks, 10 weeks. So talk about feeling abandoned.
Wow, I'm so sorry to hear that, but it's so wonderful that we, that our work, we know what nurses do. I wanted to, I was thinking of something.
Just to comment, Wendy's experience and the 60 NPs in long-term care, I would say, was similar. We had twice a week webinars with them. We cry all together. We cried all together. It was heart-wrenching. But they have the expertise, but they didn't have enough people to even delegate anything.
No, I was working, and thank God I was a nurse, right? So you're a PSW. I would write the orders. I would process the orders. I called families. You worked full scope, toilet, feed, transfer, and then we had to do end of life care totally on our own too. And yeah.
But picture then, because Wendy said in the midst of the previous statement that in the other homes, no doctors were there.
Right.
These 60 NPs were there physically, 16 hours a day, every day. And hence why the 1 NP for 120 residents is a must. And they also had an emergency order to act as medical directors. So, hey, it can be done during COVID. How about it can be done all the time? And that is our conversation with the commissioner.
Yeah. And that one physician who would only let me syringe ears called me the other day and thanked me personally for what I've done for all her residents that live at Greenwood, because they still have not been in. So we've been managing all their care, and there's a retirement home here as well. So those folks in retirement home don't get out either, right? So I've been doing all of their medical care and connecting then. So I assess them in-house and then connect with things on the outside and order. And so they get it now, they get it.
A true hero, a true hero. But going to Barb's presentation, look what you said. The physician called you to thank you for taking care of her or his patients. A nurse will not say that, will say of patients, because patients belong to themselves. You know what I mean? The whole conversation of our colleagues in medicine is wonderful when they thank us, but these are not their patients. They're their own, the patients. If anything, they're from the families. And we need to reshape that conversation. Pieces to take for the last session, Barbara. Because these are the heroes. These are really the people that were there 24/7. 24/7. The NPs and the directors of nursing, and Wendy did. We should put that. I don't know if Catherine, you can find the link to the webinar, the video that Wendy and the director of nursing at her place did, because not for now, for people to take with them, you should show to everybody. To everybody. An amazing
I will look for that, Doris.
Partnership, a partnership second to none. Kudos, Wendy.
And COVID has changed long-term care more than I think any other sector. Our lives are absolutely every piece of what we do in long-term care has been impacted with COVID.
Yeah, I would say that's true across the board. Absolutely. And I wanted to say what you were saying, Wendy, just reminded me of, you know, the old adage that nurses are with you when you're born and are with you when you die. And we're the one constancy, I would say, in people's lives. So anyway, that was a wonderful story. Thank you. Thank you so much. So what we'll do now is we'll move on to Sarah Rice. And Sarah graduated from Western University MScN program in 2008 with a focus in wound care and education, and subsequently the NP program in 2012. Since then, she's worked in a variety of roles within the London InterCommunity Health Center with the goal of supporting individuals who experience homelessness, substance abuse, and stigma in accessing healthcare services. Subsequently, she's been involved in the development and implementation of programs of care in response to assessed needs in the community, such as primary care youth outreach, drug treatment court, the development of skin and infectious disease program, working with London's Needle Exchange, the emergency safer supply program, as well as supporting HIV primary care and trans programs. Currently, the focus of her work is providing low barrier primary care clients of all ages within the health outreach program. So, Sarah, are you here?
I am. Thank you very much.
Great. Thank you.
As you heard, I began at London InterCommunity in 2012, and it was a vacant position for quite a while when I moved into it. So I really had the opportunity to develop the role as I wanted to. And actually they asked in my interview what I would do with the role. So I was able to sort of point out some things in the community that needed addressing, like if you've got an abscess and you're substance using, you might not want to go see your family doctor. You might avoid emergency because of stigma. And you may end up losing an arm or a leg or dying because of that. So why wouldn't we just provide antibiotics in a place that you're accessing frequently, like a needle exchange? So that was a huge bonus to me and something I've carried through over the last 8 or 9 years, I guess. So day to day, my role is primary care, and I see children to adults to geriatrics. And I do a lot of complex chronic disease management, as well as acute management of disease, infection like abscesses. We see a number of overdoses, particularly with COVID and the fentanyl crisis, and a lot of mental health crises. I also have a strong component of mental health and substance use management, recognizing that there's a high amount of trauma experienced by my clients and within the community. So I have full control over who I choose to roster and not. So if I, hear from one of my community partners that so-and-so is really having a rough time or is, 34 weeks pregnant and heavily substance using, I can say if this person's a priority, I'm going to take them immediately. I will go see them where they are in the community if they can't come to me, which is a huge bonus and really makes my role much more enjoyable. So recognizing also that a lot of my clients are substance using at a high risk of death, high risk of complications related to the toxic street supply, I provide safer supply services to a number of clients, and I also do the assessment for the wider program at London InterCommunity. So this means that I provide dilaudid tablets to a select number of clients to help remove them from the fentanyl or from having to buy fentanyl during the week. One of the other things I would say about my role is that because in a community health center, our management is quite flat. I have a pretty high autonomy and also the ability to talk directly to my leadership. And I feel like my voice is pretty valued, which means that I have a role in development and policy and program within the health center. So otherwise, day to day, I also have a role within education for the rest of the nurses at the health center, and both with nursing students and nurse practitioner students, we also quite frequently have medical students coming through. And I have a strong advocacy role with clients, as well as with the policy and procedures within the health center. During COVID, we've as I'm sure most people had lost a number of clients due to the lack of access to services. As well, we've had a number commit suicide and a number die related to overdose. And so that's been incredibly difficult over a long period of time. Like, it just continues. It doesn't seem to get any better, particularly with the winter coming and facilities still being closed. It's just really hard. The health center, when COVID first happened, as nurse practitioners, we came to our leadership and our management and said, like, how are we going to help serve these clients? We can't do phone calls. People don't have phones. We can't do home visits. People don't have homes. How are we going to serve these clients? So day to day, my life hasn't really changed. We've had to remain open. We've supported a strategy and advocated for a strategy with the city where clients who can't access the normal sort of way that you would get swabbed can come to the health center, and we'll swab them there and then support them at a motel. There's sort of like an isolation motel in London that we can send people to. But also sort of thinking about, like, hey, if people can't access showers anymore in the community, what happens? Like, it's 8-9 months now, where are people accessing hygiene? What are the long-term implications of this? If we're in COVID, how are people going to sanitize their hands? So we've had a lot of discussions about that and a lot of ongoing talks at both the health center and the city level. Yeah, I guess I'll stop there because I could go on for quite a while.
Thank you. I would just like to mention one thing, and I think it was really related to Barbara's wonderful talk a little bit ago, is that it really sounded like you have ownership of your voice and that you are proud of that. So I think that's wonderful, and it sounds like you're not afraid to speak up, which is great.
I think the longer you're in a nursing role, the more you realize conflict's not a bad thing. I don't have to be liked by everyone. It's okay if you don't like me, but the priorities of my client are what needs to be met here. And so how do we do that? And it's okay if you don't agree with me right now, but I'm going to come back and talk to you about it again.
Right. But the one thing, and I will never forget, my dean, my undergraduate program said, if you always couch your argument in terms of the patient, no one can argue with you because it's always about the patients. And so how could anyone possibly argue? So that's a great way to approach it, I would say. So great. Thank you so much. Why, this is so interesting. And finally, last but not least, we're going to move on to Renee Bradley. Renee completed her BScN at University of Windsor and completed her nurse practitioner degree at the University of Toronto in 2016. Her clinical background includes a variety of practice settings of surgical intensive care, complex continuing care, and women's health. Renee is dedicated to increasing access of healthcare services to racialized women. And outside of direct patient care, Renee is a member of RNAO's Black Task Force and a clinical instructor at George Brown College. So Renee, welcome. Are you here?
Sorry, I was muted there. Can you hear me?
Oh, there you are. Hi.
Okay, great. Thank you.
Hi.
Thank you for that introduction, Elissa, and thank you for the opportunity to speak to you all today. So currently I'm a nurse practitioner at Women's Health and Women's Hands Community Health Center in downtown Toronto. And we're the only CHC in Canada that prioritizes racialized women as our priority population. So my clients are largely African, Caribbean, Black, Latin American, and Southeast Asian descent. And we have other priority groups within that, including pregnant women, transgender clients, and HIV positive women. And my role here is mostly direct patient care with some time spent on interdisciplinary teams with our focus on mental health, diabetes, and HIV care. The main interesting feature about my CHC is that most of our clients are uninsured, as in not having OHIP. Many of them are new to Canada or on refugee status. Because of this, we have a large budget that supports uninsured clients in terms of specialist fees and diagnostic fees, and that really allows access to healthcare services in a more equitable way, especially for very marginalized women. In addition to the medical complexity of my clients, I find their various social issues even more complex, and that can range from housing issues to immigration issues, food insecurity, and I see a strong correlation between social determinants of health and their healthcare outcomes. But on top of that, most of my clients have trauma in the background of their circumstances. So my practice is very much from an anti-oppressive and trauma-informed lens. So in this role, it's really important to consider an expanded definition of trauma that really speaks to the complexity of the human experience, and my clients, particularly in relation to like intersections and factors of identity, such as race, socioeconomic status, gender or gender identity, sexual orientation, religion, or disability. So for example, if I'm caring for a client who is a sexual assault survivor of African descent, and she is seeking care for issues such as depression and PTSD, I would consider her history of sexual assaults as just one experience of violence in her life. But it's important to consider various aspects of violence in this client's life, which are influenced by her not only being a woman, but by being a Black woman. And a trauma-informed lens really considers additional factors like the history of African enslavement, inhumane rape laws, and current racist stereotypes of Black women that are perpetuated in the media. And that really influences the client's lived experience and contributes to their presenting complaints of depression and PTSD. And because my client population is largely women of color from countries with histories of oppression, war, and colonialism, it is an important factor of how historical and modern day racism or colonialism or intergenerational trauma informs the way these patients present into the clinic. So in this role, I've really learned that trauma is often the precursor for many mental health conditions, whether the client is able to acknowledge that or whether they're aware of that. And it's also common to see their trauma manifest in physical complaints like IBS or chronic MSK pain or pelvic pain. So we have to be continuously mindful of that and the lasting impacts that trauma has on both the body and the mind, and spend time educating the client on that as well. And so it's here with all the trauma-informed care that I see a lot of overlap with the NP role in social work, but we really depend so heavily on the wisdom of our social workers and our mental health therapists within the clinic. And they've really helped me to gain a lot of insight into the nature of a lot of the mental health concerns that I see in my practice. I don't recall trauma really being touched on in nursing school or NP school, but I think it's a really important element to add in the curriculum that would really enhance the nursing education. In terms of challenges, I think the greatest challenge of this work, and probably seen in other helping professions, is vicarious trauma, as in like the trauma that occurs when we're hearing or exposed to difficult images or hearing stories secondhand. And it can be very challenging to hear those traumatic stories day after day, and oftentimes being the first one that the patient is disclosing their story to. And it can be challenging to hold space for that. So I've had to learn in this role to really be aware of my own emotional boundaries and practice grounding, sometimes before, after, even during the appointments, by taking deep breaths or planting my feet on the ground or running cold water on my hands. But the greatest part of this work, I find, is the vicarious resilience. And I think I've seen a lot of that, especially during COVID, where for many of us, our lives have changed in that we're doing a lot of Zoom calls, or like pregnancy is something that I've seen a lot during this pandemic. And I see women who are refugees and they're pregnant for the first time and they're living in a shelter and they don't have a lot of resources available to them that would normally be there without COVID. So that really makes it easy to continue engaging in the work, to see people overcome these circumstances and not only survive, but thrive in their life. And the last thing I wanted to talk about is the NP Task Force's vision to invest in research to support NP practice and improvement of health outcomes. And I think that it's very important that research includes the collection of race-based data. And that's for a couple reasons. Like, one, we can't address what we can't measure. And currently we do have a lot of colorblind policies that keep us from addressing important disparities that we see in healthcare. And we are seeing that a lot with COVID numbers and how they're much higher in a lot of our racialized communities. And clients do have, I think, concerns about the collection of race-based data in terms of like those stereotypes being perpetuated in the healthcare system, or fears about not accessing quality care if they disclose that they identify as Indigenous, for example. But it is really important that as healthcare providers and healthcare administrators that we really start to examine how we are perpetuating racial inequality in our practice and in our healthcare system, and what we can start to do to really overcome those issues. And I think I'll stop there.
Thank you. Wow, what an amazing practice you have. That's amazing. What you're doing. I did want to kind of interject in terms of what we have been looking at a lot here in the US, and I don't know if you all have been doing this, but recently the whole issue of race-based assessments and lab tests that really kind of undermine the ability of African Americans to be able to access care, especially around, for example, kidney function, dialysis, et cetera. So, I mean, there's there's so many dimensions to that. So anyway, thank you for bringing that up.
Elissa, just one
Yeah.
second. So
Sure,
you
sure.
may remember, just to connect the dots, that at the beginning we shared with you the frameworks that we are using to guide our work. And you may remember we spoke about SDGs and we spoke about the quadruple aim. I think when you look at each one of these presentations, you will see elements of that. And I think in the report, from time to time, we need to make sure more and more, perhaps, to look at again at the report, to connect the dots with narratives of these practices that we heard today, Catherine and Nirmajin and I, that I'm involved on that too. You know, to look at the videos and snippets of these presentations, of course, with permission from the first people that presented, even as mini videos, and then connected to the frameworks, because they're so powerful, so just very powerful. Each one of your practices, each one, amazing, just amazing panel.
Yeah, thank you all so much. And I guess Catherine or Doris, I'm not exactly sure where we go from here.
I will lead us.
Okay, thank you. Thank you
so much, Elissa, and to all of our panelists who just shared their really valuable stories. Thank you so much for taking the time to join us today. So we are now going to move on to concurrent sessions. Just before that, though, we would ask you to, again, all answer a poll. Oh, actually, I've just received a note that the poll is not working. So in the interest of time, we will move on to the concurrent sessions. Please, you'll need to pick either concurrent session 1, which is experiences and lesson learned from COVID-19, perspectives from acute care and working with Indigenous populations, where you will hear from Suzanne Robichaud as well as Eric Rankin. That is happening concurrent session 1. There is a Zoom link provided there. And Irmajine, I'll just ask that. Yes, you stopped sharing. Perfect, thank you. And concurrent session number 2 is experiences and lessons learned from COVID-19, perspectives from academia and mental health and addiction. We have speakers Dania Versailles and Sherry Morrell. So we'll ask you to pick one of the 2 sessions using the Zoom connection details that have been provided in the chat. Before you do leave this main session, please make sure that you write down the passcode and the meeting ID or take a photo if you do not have that email readily available. The links were sent again this morning to everyone, so you can refer back to email. However, if you prefer to access it straight from the chat, feel free to do so. Just make sure you have the meeting ID and passcode. So we'll have you zip off to the concurrent sessions for 45 minutes. And we'll come back here at 2:15 p.m. as we move on with the rest of the agenda for the day. Okay, so we'll see you in 45 minutes. Thank you all so much, and we'll see you back soon.